In the vascular disease lecture, we're going to be talking about peripheral vascular disease, and mainly as it relates to the lower extremities. I want you to see vascular disease of the legs as either chronic, peripheral vascular disease, or acute limb ischemia. Peripheral vascular disease is the one you have to know the most about, and acute limb ischemia we'll touch on. So let's start with peripheral vascular disease. And peripheral vascular disease is essentially coronary artery disease. That is, it's the same disease, just in a different place. You got blockages in your leg arteries, you probably got blockages in your heart arteries, and they got there the same way. So anyone who has peripheral vascular disease should be treated as though they have coronary artery disease. So you get peripheral vascular disease in the same way you get coronary artery disease. That is, the hypertensive diabetic smoker with bad cholesterol. And for whatever reason, there seems to be a higher incidence of peripheral vascular disease in women more than men. But anyway you get there, you have the same thing. I'm going to keep making this reference to coronary artery disease so you can see how they correlate. The person who has peripheral vascular disease is likely to present with leg claudication. See this as angina of the leg. As the person exercises, they start to use their muscles. The demand of the muscle goes up, but the oxygen supply isn't matched, so it hurts. Pain in the leg on ambulation is indicative of peripheral vascular disease. But here's the thing. You have symptoms of claudication distal to the obstruction. Most people are going to experience this in the lower half of their lower extremity. When you hear claudication, you should immediately rule out spinal stenosis. Spinal stenosis has nothing to do with vascular disease. It presents with claudication of the buttocks. That's better when you lean forward. The position change doesn't make any sense for vascular obstruction, and since you know there's pain distal to the site of obstruction, if there were buttock pain and a vascular lesion, that would have to be the abdominal aorta, and there'd be no blood flow to the lower extremities at all. So if you see claudication, don't jump to peripheral vascular disease. Look for spinal stenosis first, and then after that's off the table, resume peripheral vascular disease. But some people may not present with claudication, and most people do not. A lot of people are going to present with non-healing wounds. And if they are severe, and this is going to be more for the test than it is for real life, because very few people actually present this way, they're going to have rest pain. Or they're going to have change with position. What I mean by this is they hurt, they have ischemic pain just sitting there all the time. Or when they're in bed, they don't have any flow because they're in line with their heart. They're going to have pale feet that start to hurt because they become ischemic. They dangle their feet over the edge of the bed and all of a sudden they turn purple because the perfusion has returned. That's indicative of someone who has severe peripheral vascular disease, also fairly rare. But you might identify someone with peripheral vascular disease just on a physical exam. They may not actually have any symptoms at all. If you see shiny shins or loss of hair, especially compared left to right, think of peripheral vascular disease. But because this is a problem with perfusion of the lower extremity, you're going to have problems of pulses, decreased pulses, and cooler temperatures. Again, especially left to right. Cool extremity is indicative of poor perfusion. So if you see somebody you think might have peripheral vascular disease, the way you start the workup is with an ankle brachial index. You measure the dorsalis pietis pulse and the posterior tibial pulse, and you compare that, whichever one is greater, to the brachial. Now, if you have an ABI greater than 1.4, that is calcified vessels. You can't use it. That shouldn't happen. So if that happens, then you're going to have to go for a toe brachial index. A normal ABI is 1 to 1.4. 0.9 to 1 is equivocal. That's not very useful because you don't know if there is a disease or there's not. So if you have an equivocal ABI, you should then follow it up with an exercise ABI. This will figure out who has the disease and who doesn't. And then, as the ratio gets worse, so too does the disease. 0.8 to 0.9 is mild. 0.4 to 0.8 is moderate, and less than 0.4 is going to be severe. After the ABI is positive, and whether that's the TBI or the exercise ABI doesn't matter, once you have a positive ABI, you then want to try to find the source of the lesion. So you're going to do an ultrasound with Doppler. You basically go down their leg until the signal drops all of a sudden, and now you found the location. That's where the problem is. This is usually a macrovascular disease. And you might think, oh, well, since I need to get in there, I must have to do an angiogram. And you're sort of right. You do not do an angiogram where you actually puncture the artery unless you're going to intervene endovascularly. So after the ABI, you do the ultrasound with Doppler, and then you follow it up with a CT angiogram, which is just as good at visualizing the leg as is an actual arteriogram, but doesn't have any of the risk. And then you ask, do I really need to fix this person? Right? You've identified their disease. Can you just manage them medically? You only intervene on someone with peripheral vascular disease when it's going to improve their lifestyle and medications have failed. The postman who's 55, who happened to smoke, who has to walk his route, who can no longer walk, probably should be fixed. The 85-year-old bedbound patient in the nursing home should not have a stent placed. So you actually, as part of the workup and as part of the question, it's going to be assess the person's net need to get revascularized. And if it affects their lifestyle or there's been a failure of medical therapy, go for it. The treatment is going to be either with angioplasty and stenting, that is endovascular, or it's going to be bypass. You connect good arteries around the blockage and bypass the stenosis. You stent above the knee and small lesions. You bypass everything else, that is anything that's below the knee or a long lesion that a stent can't capture. But of course, this is like coronary artery disease, so you have to treat them medically. And medical management is going to be essentially identical to coronary artery disease. You treat the hypertension with beta blockers and ACE inhibitors. You get the A1C less than 7. Everyone should benefit from smoking cessation. You get them on a high-potency statin. And not just women, but everybody needs an antiplatelet. Aspirin or clopidogrel will do. People have looked into using anticoagulation like warfarin and then novel oral anticoagulants. Those don't do anything. Treat it like coronary artery disease, aspirin or Plavix, and then use the other stuff to manage the risk factors. But in addition, if someone's not a surgical candidate, you don't want them to hurt. So you can use other medications that don't do anything for the prognosis, but increase exercise capacity, make the person feel better. This is going to be cilostazol and pentoxifylline. You pretty much won't see these medications anywhere else. You can't use them in heart failure, but if all they have is peripheral vascular disease and all you want to do is make their symptoms less, use these. This is why they're usually the wrong answer on the test, because they don't do anything. Smoking cessation, risk factor management, and getting them reperfused is what matters most. So now you kind of understand the unstable angina coronary artery disease version. Let's talk about what happens when they have a heart attack. That is to say, when they have acute limb ischemia. And just like an MI, they have not had time to develop collaterals as they have had in the chronic disease, peripheral vascular disease. This is when they have a complete loss of perfusion to a limb and it's acute. This is going to happen in a couple of ways. You can have a cholesterol embolism following a cath. This is more useful for a vignette. If you see in the vignette that they had some manipulation of the aorta, or there was an angiogram or something like that, and now they have acute limb ischemia, it's cholesterol embolism. You can get a clot embolize as an AFib, but usually we associate that with a stroke or more rarely with mesenteric ischemia. What's more likely is that they had a heart attack, that is, they had a thrombus form on top of peripheral vascular disease. And remember, no time to develop collaterals, no perfusion at all, you get the 6 Ps. Because there is pulselessness, no perfusion to the distal tissues, they're going to get pale. And that limb is not getting any warm blood, so it's going to get cold. The way you say that, to use a P, is poikilothermia. All it means is that the limb is cold. Because it's ischemic, not getting any blood flow, it's going to hurt. And as the foot begins to die, it stops doing what it's able to do, which is move and feel. So you'll get paresthesias and paralysis. The further along you get and the worse it is, the more likely it is the foot is dead and needs to just be chopped off. But if you've identified someone with acute limb ischemia, you got about 6 hours to fix it, otherwise it's gone. So the diagnosis begins with the ultrasound with Doppler, trying to identify where the area is lost. And here's where you're going to jump on the angiogram because you need to get in there and fix it. This is like a STEMI. You have to get in there and do some endovascular procedure. And to fix it, you're going to do either an embolectomy or TPA. And ideally, you'll do intra-arterial TPA directed at the thrombus. But because you have dead tissue on the other side, when you reperfuse, there's a chance that you cause compartment syndrome. So anyone who gets reperfused needs to be assessed for compartment syndrome, and if it develops, you need to cut them open to relieve the pressure. So I want you to feel the difference. Peripheral vascular disease, lots to know. It's like coronary artery disease in the same way of risk factors, and essentially you have claudication instead of angina. The way you work it up is with an ABI, and you have to memorize this table. Greater than 1.4, toe brachial index. Equivalent 0.9 to 1, exercise ABIs. The ABI is positive, do the ultrasound with Doppler, then a CT angiogram. You stent lesions above the knee, you bypass lesions below the knee, or those that are big. You use regular medical intervention to control the risk factors, and if you need to control symptoms, cilostazol and pentoxifylline. Different from acute limb ischemia where you see the 6 Ps, it's much more acute and you just have to get in there with the angiogram to try to fix them, otherwise they lose their limb. That's vascular disease. Become a better doctor. Subscribe now to get access to our premium content.